As a prelude to Michael's talk, I thought I'd just cover a few of the things that are happening in the field of depression. And I'm going to go through these slides pretty quickly so we can give full due to the psychopharmacology material that I'm sure you're all interested in hearing about. First, I want to just give a few disclosures. I will mention a computer program that I've been working on that's available commercially, and we do receive royalties for that. And then I receive royalties for books that I've written, and I think I might mention a book or two in the presentation today or this afternoon. So first, what are the problems in the treatment of depression? As you know, you're all clinicians, you know there are lots of people out there with mood disorders. The most recent data that we have show that about 1 in 5 Americans suffer from a mood disorder sometime during their lifetime. And the striking thing about this is that there's a fairly high proportion of these people that have bipolar disorder. When I went to med school, we were told that about 1% of the population had bipolar disorder, but it appears that that was wrong, that bipolar disorder is much more frequent than any of us thought. And there's a big problem here with recognizing and treating bipolar disorder. Annual cost of depression is enormous. The cost is partially going to treatment, but a lot of this is for lost productivity, people that aren't going to work, or when they're going to work, they're not as efficient as they once were. Here are some problems that really stand out to me. One of the studies found that more than 60% of the people with mood disorders receive no treatment at all in the first year after the diagnosis. Pretty amazing, isn't it, that people are out there suffering for that long without getting any treatment whatsoever. Another study found that only 20% of the people with depression were receiving what was called adequate treatment. By adequate, we meant a decent course of an antidepressant for long enough or an evidence-based psychotherapy. Full remission is relatively rare, as you're going to see in the talk by Dr. Thace. We'll go into this in considerable detail in that presentation. Recurrence is an enormously big problem. About 2/3 of people with depression are going to have a recurrence. And if you have bipolar disorder, it's almost a certainty that you'll have a recurrence. Non-adherence, again, as clinicians, you don't need to learn about this. You know that many of your people that you see for mood disorders don't take their medications. And then we have limited utilization and access to effective psychotherapies is another problem in treatment. So what progress is being made when we have this landscape of difficulties in the treatment of mood disorders? I just thought I'd give you a brief sampler of some of the things that struck me as relatively important newer findings. One of the areas of research has been genetics, and one of the studies that is particularly interesting is one that was reported in Science just a few years ago, and I'll try to explain this to you. The slide shows the distribution of alleles that are given, one from the mom and one from the pop. We have here either you got a long or two long alleles of the serotonin transporter gene. This is a gene that controls the transport of serotonin across cell membranes in the brain. You could either get two longs, a short and a long, or two shorts. And we all have this gene, by the way. And it turned out that in this study, and this has been replicated, that if you had maltreatment as a child, that your chances of getting depression were almost double if you had this short allele. So this is a beautiful demonstration of what we've all suspected all along, that there's an enormous interaction between our genetic contributions that we get when we're born in the environment that we live in. Now, if you were lucky enough to get this long allele, then no matter what your childhood experience was, this is no child abuse, some, probable, and severe, it didn't make any difference in regard to your vulnerability for depression. But if you got this short combo, it made an enormous difference. So these findings, I think, will eventually pan out with trying to do better diagnostic assessments of patients, even doing genetic studies of patients, and helping us predict what kinds of treatments might be best for them. There's another area of research that's very exciting, and that's neuroimaging. This was a cover of the American Journal of Psychiatry just a couple years ago that looked at changes in brain functioning with various mood states like loss and grief. Here's a summary slide based on research by Charlie Nemiroff at Emory. And these findings have been replicated fairly consistently. The main thing that's going on here is that there appears to be an increased activity in areas of the brain that are associated with the limbic system, particularly the amygdala, the cingulate gyrus, which I'll give you more detail about in just a few moments. And at the same time, there's reduced activity in the areas that we try to attack in cognitive therapy, the frontal cortex, where we do most of our conscious thinking. So that's damped down, whereas there's an increased activity in this so-called vegetative brain, or the basic inner part of the brain. Here's a slide that I found quite fascinating. This was prepared by Dr. Nemiroff, so I borrowed this from an article that he published. The previous slide had the reference in case you want to go into more detail. This is work on the anterior cingulate, which, if there's one area of the brain that seems to be associated with depression, that's it. And this is some neuroimaging work that shows that a number of different attempts to modulate functioning in the anterior cingulate have all shown about the same findings. And that is that if you give an SSRI, it's a serotonin reuptake inhibitor, you treat with magnetic stimulation, transcranial magnetic stimulation, electroconvulsive therapy. If you put an electrode in the brain, this is called deep brain stimulation, where an electrode is actually placed right in that anterior cingulate gyrus. Or you do tryptophan depletion. All of these things damp down this hyperactivity in the anterior cingulate. And there have been some studies now done with deep brain stimulation in treating refractory depression, which is fascinating, of people that have not gotten better with a myriad of treatments that now have had this electrode implanted in the anterior cingulate, and it's been able to show that these people have had fairly dramatic responses in improvement of depression. This is not available for clinical use yet. You can't refer a patient to the depression center at the University of Louisville and have an electrode planted in their brain, but it may happen sometime in the next few years that these treatments will be available broadly. They're just used in research settings at the present time. An exciting area of research. And then moving on to research on psychosocial treatments, this is a summary slide of studies on cognitive behavior therapy, antidepressant drugs, and combined treatment. If you've heard me talk before, you've probably seen this slide, because this is a thing that I like to get across to people, that both of these treatments work. That is CBT and medication. But if you put the two of them together, you get an edge. In these three studies, the edge was not statistically significant because there weren't enough people in the study to show that. But in this study, which was a very large study, it was statistically significant. And if you pull all the studies together in a meta-analysis or a mega-analysis, then this effect is consistent. So we can generally expect that by combining psychotherapy and pharmacotherapy, we get a better result in the treatment of major depression.